Hi, everybody. Thanks for coming back after lunch. I hope you've enjoyed the conference. I've enjoyed meeting several of you between sessions, in sessions, and that networking and collaboration gives us all a second wind. So we can go back and be even more effective just after working with each other. So I appreciate you being here. A strong healthcare system is one of the major pillars in the foundation of a healthy, prosperous nation. But our health system fails older adults and others living with chronic conditions. Part of the reason for that is healthcare professional training and administration acts like we're still back in 1960, where people got sick and either they got better or they died. Today they do neither, but we are still trapped running and doing acute care, trying to keep people from dying from medical catastrophes in episodic episodes. And what we should be doing is guiding people to live through the dynamic care changes over time, because we're dealing with chronic disease. The other way that we fail is that you can get paid to do things to people, not for people. You can bill for prescriptions and procedures and tests, but you can't get paid for the thinking and the hearing and the collaboration and the planning that you need to do chronic care well. We also subject many of our citizens to challenges with access to care. And many of our citizens have to put up with bias, racism, sexism, ageism, all other kinds of stigmas. And that compromises the equity of whatever care we're giving. So we have a challenge today. The key is to invest in a chronic disease strategy that not only brings evidence-based interventions to treatment, but also to focus on prevention and equity. Now, this year, NCOA did a What Women Say survey, and they asked over 1,000 women who are over age 25 about their health concerns. About a third of them said that they had delays getting care. 20% said they had delays getting prescriptions refilled. All of them want solutions. And 95% of them want to expand Medicare coverage for comprehensive discussions of all the different ways that we care for serious chronic illness. Now, we have chosen obesity, a chronic disease, as a way to talk about the access to care, the primary care issues, and the equity issues surrounding the management of chronic disease. And I am honored to be with an illustrious panel, including Patty Nece, a lawyer who is the immediate past president of the Obesity Action Coalition, Dr. Kimberly Rogers, owner of RestoreMD Medical and Wellness, and NCOA's own Dorothea Vafiadis, our senior director of the Center for Healthy Aging. Now, Patty, I'm going to start with you.
Okay.
You've told us that you've had problems getting care for yourself.
Right.
How did you navigate the system, and can you give us one example of what you had to put up with before you found a doc who actually listened to you?
I'm happy to. So I have the chronic disease of obesity. Now, it may surprise you that I'm calling it a chronic disease, because even though the AMA declared obesity a chronic disease more than a decade ago, socially, people still see it as a personal responsibility, generally speaking, that if you just eat less and move more, you lose the weight. Weight is totally within your control. And as a result of bias, those of us who live our lives in larger bodies have faced ridicule, discrimination throughout our lives. I've had obesity since I was a child. I was always a big kid in school. Kids called me Fatty Patty. They like rhymes. Kids like rhymes. That was a good one for them. I had a school nurse say in front of the entire class, "You need to lose weight, you're fat," when I was in elementary school. There was the guy in high school who said, "I'd date you if you weren't so fat." All of those things continue throughout your life, including just anonymous people when you're out walking down a sidewalk yelling things out of their passing car windows like, "You big fat cow," or "Shamoo," as they trail off into the distance. And you would think that healthcare providers might be immune to those biases, but unfortunately, they're part of our society, just like everyone in this room. And you're told your entire life, I was told my entire life, that weight was all my fault, that you don't have enough willpower. If you just push away from the table, you'd be okay. And I'd hear this from the medical community. Lots of finger wagging, literally, I'm not kidding, saying, "You need to lose weight." Gee, I never thought of that before. Despite the fact that I had been on diets since I was in junior high, and I always lost some weight, and it always came back. The diets never worked for me. And invariably, as my friend Michelle says, a few friends come back with the pounds you already had. So your weight is even higher than when you started, which is pretty typical. So when you seek medical treatment, and I'm an award-winning attorney. I'm sorry, I don't lack willpower. That's not a problem. It's because obesity is physiology and genetics and biology and hormones. It's not a behavioral problem, yet we address it far too often these days as a behavioral problem alone. I'm not saying behavior change isn't part of controlling weight, it is, and improving your health. But I had doctors who would also, in addition to just the finger wagging, who missed MISSED diagnoses. I had an orthopedist diagnose me with obesity pain. You ever heard that diagnosis? Anybody? No, because it's not a real diagnosis. And you know what he missed? A 60-degree curve in my spine. I have severe degenerative scoliosis, and I didn't realize it had gotten that bad. And I wish I could tell you that's an isolated incident, but it's not, especially for women, because women have the dual bias of being women and obesity. Women have died because of misdiagnoses, because of physicians and other medical professionals attributing everything to weight. I now have found real care for my obesity through an obesity medicine specialist who knows the science, who knows the treatments that are in the toolbox, and who has been able to guide me through the process. And I am now managing, for the first time in my life really, managing my weight better than I ever have before. And that's the kind of care that people need. The other thing I want to point out, given the focus of this audience, is that older people are particularly susceptible to not getting treatment for obesity because Medicare really doesn't cover it. It covers bariatric metabolic surgery, but it doesn't cover obesity medications, and it barely covers intensive behavioral therapy. So
I am really,
all those people
really
left
sorry
off.
for my profession that you went through that.
Thank you.
But Kimberly, how common is that? Well, have you seen that in your practice? And what do you think we need to do to change that?
So, Patty's story, unfortunately, is so common. I am a primary care physician. I specialize in internal medicine, lifestyle medicine, and obesity medicine. So I have an integrated practice that addresses all of those things. And I see the patients every day that come in with the same story. It's such a sensitive issue. I mean, patients will literally cry because there's just such an overwhelming feeling of the healthcare system is against them. They have this feeling of bias and stigma. So when they come to, my practice, which I try to be very holistic and, really emphasizing obesity is a chronic disease. I had a patient who said, "You're the first person who has ever said to me obesity is a chronic disease." And it was so empowering for that patient who, again, is a high-powered professional. It's not a willpower issue. It's multifactorial. But this is the way that the healthcare system is. And one of the things that I always try to emphasize when it comes to obesity, chronic disease management, is just that we are really operating within a system that is not set up for the type of care that we need. So whether we're talking about obesity or all these other chronic diseases, the problem is, people, as the patient, trying to provide the doctor perspective, patients get this sense that I go to the doctor, it's a 10, 15-minute visit, they barely scratch the surface. They just, wag their finger and tell me, you need to do this, you need to do this, here's this medicine, see you in 6 months. I always try to explain the why behind that because I think it's very important. I think that there's so many different factors that patients, and all of us are patients. Even though I'm a doctor, I'm also a patient. I have patients, my family, everybody is a patient. So I always try to emphasize the why behind it because I think it's important to understand that in order to know how do we tackle this. We have a very reactive healthcare system. It's about ticking the boxes. You come in with high blood pressure, the insurance company is going to, pay the doctor if you prescribe the medication or you do whatever. I can sit there for an hour counseling patients, and if I don't document that appropriately, nobody's getting paid for that. Not saying that doctors should only, treat patients for what they're getting paid for, but the problem is the whole system is set up that way. The fact that a patient will be more likely to get covered for a bariatric surgery rather than I'm trying to prescribe my patient, Wegovy and having to fight battles. I was just telling Patty today, I spent time at this conference upstairs in my hotel room for 30 minutes trying to do a prior auth appeal for an insurance company because my patient had lost 30 pounds and apparently the documentation didn't prove that the medication was working, so they denied the reapproval.
Even though she lost 30 pounds.
Right. And this is 6 months after the initial prior auth. So why am I doing prior authorizations every 3 to 6 months for the same exact medication? So patients, from our standpoint, we're fighting a battle as well. Patients come in for their once a year kind of wellness checks, and what they don't realize is that these wellness visits actually don't involve any kind of care. It's looking at, did you do your mammogram? Did you do your colonoscopy? If you have a problem, visit. Oops, sorry, we can't talk to you about that. Your insurance isn't going to pay for that. You need to come back in. So what I see so often is that chronic disease care is not really addressed at the visits. And I also see patients get so despondent about the lack of care that they don't really also follow up. So one of the things we were kind of thinking about is how do we address that? What advice would I give? And one of the things I would say to try to empower patients and self-efficacy is really understand that the system is not set up for the type of care that we deserve. And so you have to advocate for yourself. Come in, go get frequent visits, get your maintenance visits. If the doctor can't talk to you about it on this visit, set up your follow-ups. I see so many lapses in care, especially with the pandemic. There's a crisis in chronic disease right now because of all the screenings and all the maintenance and all the misdiagnoses. So is really complex and
So the system is set up for this not to work for chronic disease.
exactly.
So Dorothea, can you tell us about the national statistics? What defines the challenge that we're facing?
Well, you're going to be surprised with these statistics because they're not good. But according to NCOA research, we know 95% of older adults are living with at least one chronic condition, and 79% have at least two. But 42% of older adults are living with obesity. That's more than 100 million people. And we know obesity is linked to many other chronic conditions, so heart disease, type 2 diabetes, and some cancers. And obesity leads to 400,000 premature deaths annually. Half of Americans today are on track to have obesity by 2030. And we know people with obesity have different needs, but they share common challenges with other older adults, which is a lot of what we just heard today, right here on this stage. But the healthcare system and navigating the complexities of the healthcare system includes facing stigma, bias, ageism, all the things we're fighting against, and it's very challenging.
And the system being set up so that even if you do get it, it doesn't work as well as you'd like. Another finding from the What the Women Say study was that the women thought that having a low income was the biggest negative factor for them getting care for their chronic condition. They also recognized the triple whammy of having a low income and being a woman of color.
Yep.
Just for everybody, what social determinants of health do you think are the most impactful in the situations that we've been talking about?
Yeah, I can start. It's clear that women of color who have obesity, and that's the space I'm working in, earn less. I mean, women earn less to begin with. Women of color earn less than someone like me on average. And then women of color with obesity earn even less. So combining these biases together makes healthcare and everything else even more inequitable. And in the obesity field, a Canadian obesity specialist, Dr. Sean Wharton, looked at his clinic, and he compared white women with women of color. The white women were losing more weight, yet they're going to the same obesity medicine clinic. And they dug deeper. And what they found was that the white women in the practice were able to leave their jobs to go to more appointments and to get more support within the context of their weight management clinic than the women of color. And once they adjusted for that, the weight loss was the same, but it just shows, and then what they did, this was pre-pandemic even, they developed more care for women who couldn't leave their jobs, like they had evening hours, or they tried to accommodate them to make it a more equitable system. And I just applaud him for even looking that deeply at the issue and trying to come up with solutions for it, because it's a huge issue.
Kimberly, you have a comment?
Yeah, that doesn't surprise me at all. I've been practicing for almost 10 years in a variety of different systems. So my first practice after residency, for 6 years, I was in kind of a value-based care model with Medicare Advantage older adults, and they were, socioeconomically disadvantaged, largely minority patients, and just the very basics of care were so difficult. Just transportation, co-pays to see specialists. I mean, that's a big part of the reason why I even got into studying lifestyle medicine, which is, evidence-based ways to help talk about lifestyle modifications, which we don't really talk about enough at the doctor's office, because I kept seeing that there were so many root causes. The root cause to a lot of these chronic disease had so many things to do with these kind of social determinants of health, and patients just had such barriers to access that I was trying to figure out ways as a doctor to help patients have some self-efficacy and figure out how they can manage things on their own. When I say on their own, with support, because a lot of people feel so overwhelmed. I don't even know where to start when it comes to, lifestyle modifications. But when I switched, I moved, got a job in private practice in a suburban place, and the differences in health outcomes, it was just startling. It was actually almost embarrassing. Like I went from a situation like patients couldn't afford a copay to see a dietitian to, patients who are talking about their second homes and, they just, it was crazy. And when I would see the health outcomes, when I would see the difference between an 80-year-old wealthy white female compared to the same, an 80-year-old disadvantaged Black woman, it almost kind of makes you angry because there's so many things that are out of their control. And right now in my practice, I see a variety of patients, which I love having that. But I do see the same thing where the barriers to care a lot of times, especially in women, because one of the issues that women have is that we are not just taking care of ourselves, right? You're taking care of your kids, you're taking care of your parents. Mm-hmm. So many of my patients are in that age demographic where they're making sure their kids are seeing their pediatrician and getting their dentist appointment. They're taking their parents for their appointments, and then they come in when they have a little bit of time left, and they're a mess. Yeah. And my job is to be like, listen, focus on you. That's what we need to do right now, because you can't focus on anybody else. But that's the reality of so many women and so many people in that kind of disadvantaged demographic. So we really have to be aware of that.
The caregiver issue is really critical. I had a 58-year-old caregiver drop dead and leave two 80-year-old people here.
Oh my gosh.
I mean, she knew to the last pill when their prescriptions were going to need to be filled, but she hadn't had her blood pressure checked in forever. She didn't know she was diabetic. It looked like that heart attack came out of nowhere, but it didn't. So the caregiver issue is really important. The other thing is the question of health literacy, which was the previous presentation. Dorothea, do you have a comment about how health literacy impairs that?
I do know that I had a privilege of going around the country last year to talk to older adults about what they're facing when it comes to accessing care, and they feel stuck. Older adults feel stuck. They don't know where to turn. They don't know where they can find credible resources. They also feel when it comes to obesity that it's their own fault. I heard a lot of people say, I know what to do, but I just don't have willpower. And that's not right. So I feel that it's important to help everyone, but older adults especially, for the healthcare system to help identify trusted sources of information that's reliable.
Well, this is a question, again, for all of you in terms of, you talked a little bit about how you empower people to advocate for themselves. What other suggestions do you have that we as practitioners can do to encourage people, empower them to take care of themselves and advocate for themselves?
So one of the things I try to emphasize when patients come in is that chronic disease, there are studies that show that 80% of chronic diseases are potentially preventable, treatable, and reversible through lifestyle modifications. We don't emphasize that enough, and a big part of the reason we don't emphasize that in the doctor's office, for example, is one, we don't get educated in that. Let me tell you the little secret, okay? We don't get that education in med school that is focusing on prevention. We are really good at prescribing medications. We know all the pharmacology, all the pathophysiology. We know that prevention is better than cure, but when it comes to actually taking that step to talk to patients about it, we really don't really have that, that training. And so The other dirty secret is time. What a lot of people don't realize is that the average primary care doctor has 10 minutes on average per patient appointment, and it's not because we don't want to talk to you, it's because we're in a healthcare system that is driven by things outside of our control, insurance reimbursement, healthcare systems. You have to see X number of patients a day, and you only have X number of hours in the day, so you can do the math, right? And reimbursements are declining every year, costs of running a practice are going up. So we don't have time. So if you come into the office with uncontrolled diabetes, high blood pressure, high cholesterol, you're gonna get thrown on the statin and the blood pressure medication and whatever, but we may not go the next step and talk about prevention, talk about how you can do something to impact your health. So I think one of the advocacy things I try to promote is have that conversation, say, hey, what can I do? We learned in med school, even when I was in med school, we learned that diabetes is a progressive disease that is out of our control to fix. We were just trying to slow down the progression, and now we know that's not true. We know that diabetes can be reversible through lifestyle modification. So as patients, I think just asking that extra question, if you don't feel like you're getting that type of care, advocate for yourself and find that type of care. It exists. It may not be, find the doctor that is going to be a partner in your health and help you with that comprehensive plan for health optimization, not just treating, and prescribing.
We also don't learn anything about nutrition.
Oh, yeah.
Nothing about nutrition.
Yeah.
Well, Patty, you advocated for yourself. So what do you suggest that people?
Yeah, I mean, let me add on to what you just said too, that one of the reasons to focus on treating chronic diseases is most of them are progressive and they lead to other complications. I mean, right now I'm a candidate for a double knee replacement because of osteoarthritis. And my weight has played a role in that. I'm aware of that. But that's where I'm at, and if I could have controlled my weight and all the inflammation in my body too, at an earlier stage, my osteoarthritis probably would not have been as bad. That's just one example. Diabetes is another chronic disease that leads to a lot of different complications. So focusing on treating them is important. As far as advocating for myself, honestly, I had given up on managing my weight. I gave up. I weighed about 100 pounds more than I do today, and I isolated more. I met all my professional obligations. I'd only go to places where I felt safe and where people appreciated me for who I was, not my size, and didn't care about my size. And my life became very, very small. And I think back to those days, and it's so upsetting to me that so many people with obesity and other chronic diseases do that. You get to the point that you can't face society anymore. But I eventually got tired of living that way, and I sought out, at that point, an obesity medicine physician. I live in Alexandria, which is here, and there were only 2 that I found in all my research that had science-based programs at the time. And I was in my 50s at the time that I sought this out. And I met Dr. Scott Kahan at the National Center for Weight Wellness, and my world changed, in part because he also, in addition to medical and nutritional advice, was 360-degree, also had psychological treatment for people, designed specifically for people with obesity. Because all that stigma and bias I had experienced, I turned in on myself. I'd become my own worst bully when it came to my weight. And I had to engage in stigma reduction to be able, I never would have talked about my weight before. I never talked about it. I mean, unless a doctor brought it up, I was too embarrassed and ashamed. far too much shame to bring it up myself. So for me, getting over that hurdle to begin with was how I was able to start advocating for myself and for other people. But it took knowledge, and for me, it took treatment by a couple very gifted psychologists. And that's how I got into, and I haven't been able to shut up since. So.
You're fine. I only interrupted you the first time because the timer wasn't
No,
on. I
that's
didn't know what time it was. But I, have a weight problem also. And when I became insulin resistant, I decided I couldn't do this anymore. And after I lost some weight, the insulin resistance improved. But when I wanted to continue, I got one nutrition visit for my whole life. And the only reason I got it is because I had been insulin resistant.
Right.
If I hadn't been, they wouldn't have paid for that either. Well, tomorrow is Hill Day, okay? And many of our attendings are going to go to Capitol and talk to our legislators about what we need. What do you think we should tell them that we need for management of chronic diseases? Dorothea, you want to start?
Yes. Well, one of our issues is to support the Treat Reduce Obesity Act so that those who are on Medicare Part D can get coverage for the full continuum of obesity care and treatment and counseling. So I think it's important that they realize, that elected officials realize that there's more that can be done to get coverage of older adults for chronic conditions and people living with obesity.
Yep.
What would you tell the legislators?
Man, the healthcare system just needs such an entire overhaul. It's even hard to kind of figure out where to start, but I think that, especially with obesity, I think understanding and promoting it as the chronic disease that it is, I think can help to a large degree. So for example, with, everybody knows about all the Ozempics and the Wegovy's of the world. And one of the encouraging things is they did a study on Wegovy for individuals that didn't have diabetes but had heart disease, and they found that that particular medication actually helps to reduce heart attacks, strokes, and death from cardiovascular disease. So we are kind of hoping that that helps expand insurance coverage, because we know that, unfortunately, it's more likely that it's going to get covered for heart disease than for obesity, right? And so I think that what we really need to do is promote that message and say that we just need to have that focus on obesity as a chronic disease that causes other chronic diseases. So many people have no idea. I know you mentioned it, Dorothea, but 13 different types of cancer as a direct result of obesity. We're out here fighting, breast cancer talks and walks all the time, but we're not focusing on one of the biggest risk factors for that particular, for all these different things. So I just think that we need to get the message out there that we need to demand that we take obesity seriously as a chronic disease, and we need to fund comprehensive programs. We need to look at the healthcare coverage and figure out why it is that getting surgery is more likely to be covered than a nutrition consult.
When we know that those lower cost options save money down the line.
Right.
Exactly. I think so many times they feel like they need us to prove that with the studies, so maybe we need to also kind of focus on getting those studies funded. But I mean, it just makes sense, right? That if you treat this condition that helps with other things, I mean, when we treat obesity, we're also treating high blood pressure, we're treating sleep apnea, we're treating diabetes, we're treating arthritis, we're treating everything.
You're treating the isolation that Patty talked about.
We're treating mental health.
The problems that come with isolation.
Exactly.
Right.
So much depression and anxiety and just surrounding this issue. So we just really need to hone in on that focus that we need to treat obesity as a chronic disease.
And
Dorothea, you
Cheryl,
have a comment?
I'd like to add on that, you know, when we were going across the country and we were doing research to find out what older adults feel and how they face healthcare and what some of their challenges and barriers are, we collected that information. We heard a lot of echoing stories like Patty shared. We heard a man in Mississippi stand up and say, "We live sick and we die quick." And he had relatives and grandparents and aunts who had died from obesity. We heard another woman in Wilmington, Delaware say, "I feel invisible. People don't see me, they see my body size."
Right.
And so for the first time ever, NCOA collaborated with the National Consumers League, and we have an obesity Bill of Rights. And so I'm hoping that as we continue to focus on this obesity Bill of Rights, more older adults and more healthcare providers will know that people who are living with obesity and chronic conditions have rights. They have rights to trusted information, they have rights to getting quality care, they have rights to see a specialist, they have rights to patient-centered care, they have rights to have a tailored plan for their health. So we'll be talking more about this at a 2:00 session on how we created the Obesity Bill of Rights. But I just want to mention that I feel it's important to change the narrative and change the dialogue, and we're empowering older adults to do that.
Patty, what would you tell the legislators?
Well, I'd be on the TROA bandwagon, the Treat and Reduce Obesity Act. It does two things to Medicare. It adds obesity medicines to Part D, which CMS has refused to cover without a statutory change, a change in the law. But the other piece of the puzzle actually addresses part of what you experience. Right now under Medicare, you can get intensive behavioral therapy for obesity, but it has to be administered under the auspices of a primary care doctor. Do you have time to do nutritional counseling that's in-depth meal planning with your patients? Let's think about this. The people who are most qualified for those sorts of things include registered dietitian nutritionists and some psychologists and those sorts of people. So the other part of TROA would just expand the people who could offer that care to people with obesity who are covered by Medicare.
And in community,
And right,
at community-based organizations.
that's right, that's right.
Not
So
in a doctor's office.
That's right.
I'd
So
like-
that's very important, that's an important part of it too.
I'd like to tell the legislators about restructuring the way we fund medical education,
Oh, yeah.
because most of it is funded on inpatient dollars. If you take people out of the hospital, which is where most people with chronic disease live with their diseases, you don't have funds for your training program. So that sets up a really bad way to make your hands tied. You have to come out not knowing anything about this. But those of us in the aging network don't give up. And we understand that up is that way. So I need each of you to tell me one thing that you think we can do to improve this situation for chronic care.
Well, I think the one thing is that if you make your voice heard and speak out and don't be afraid to ask questions, that will be very important. And I'm really excited by the turnout and all of the sessions that we're hearing about how to empower people who are living with chronic conditions, who are living in situations that are less than, to make their voice heard. We see that now across the country, on campuses everywhere. People want to speak out for the rights that they deserve.
I'd say be curious about people and not judgmental. People of size have been judged for eons, and it needs to stop. But that applies across the chronic care continuum. There are stigma and biases in things like diabetes, too, that I'm aware of. And we actually work with the American Diabetes Association on some issues, along with the organization I'm affiliated with, the Obesity Action Coalition. But be curious about people and support them in that whatever their journey is, rather than belittling them or demeaning them. Everyone's entitled to dignity and respect.
Dr. Kim?
I think that everybody here, something has resonated during this conversation, whether as a patient or a healthcare professional or just, a provider, a caregiver. And so there's so many things to tackle. It's just if each of us just chooses like one little pet project, something that's a special interest, and then you take that on and you tackle that. I think we can all have a cumulative impact if we address this from multiple perspectives. But I think the biggest thing really is just kind of recognizing how the system is really not set up for this, and how to now advocate for yourself and navigate it in a way that it suits your purposes and your goals, and so that we can really get that healthcare provided for chronic disease management that we're supposed to.
I think our system needs to stop working so hard to keep people from dying in the minute and stop allowing people to die by not getting in front of it. So I think prevention and education is the key. I want to thank all of you for coming. I hope you continue to enjoy the sessions and the camaraderie in between. And I'm championing those of us who are going to go to the Hill and let these people know what we need. Thank you very much.